Yeah, so let's move on to the medical, more common occurring data in the medical scale with this talk. And I've been introduced, I guess now at least 2 times today, so we'll go over this rather quickly. But one thing I did want to say is before I started studying computer science, I actually used to be a radiographer. So that's the person in the hospital that is taking all these X-rays and these CT scans, MRI scans, and that sort of thing. So I'm speaking to you today as someone who has made those scans, right? So that is my main expertise. Some of the other skills I'll be talking about, that's not really my expertise, but I want to give you an overview anyway. One benefit also of being a former radiographer is that I got to wear face masks before it became popular. So I'm very proud of this. Already maybe 20 years ago, I was going around with a face mask quite frequently. So that's fun. But all right, on topic. When we're thinking about visualizing medical data, I want to take it a bit more high level again first. You might ask yourself, why would you want to visualize medical data at all, actually? And there are several goals you can have while you're visualizing. It could be that you're doing that for educational purposes. So you want to teach some people about the data or about a certain disease. It could be that you're doing it for diagnosis, treatment planning, treatment guidance, and doctor-patient communication. There's a variety of goals you can have. But the reason for acquiring medical data in the first place are very often the middle three, so diagnosis, treatment planning, or treatment guidance. And depending on the type of disease, the body part, and things like this, one modality will make more sense than the others. So in this talk, I want to give you an overview of very basic medical data terminology, so that the next time you maybe see a medical visualization talk, if you're not familiar already, you'll think like, oh, CT, I've heard of this, and then you'll know a bit what they're talking about. In a way, it will be like a brief tour through the entire zoo of medical data, because there's many modalities and there's only 25 minutes for me to talk. It will not be very detailed on all of them, right? So if you're in an actual zoo, you sometimes have these trains that take a little tour around the park. That will be my talk, right? And if you're interested in any more details, then there will be more in-depth exhibits in the individual lectures, okay? So think of my talk as a little train ride through medical data. So finally, back to the scales where Jan left us. So Jan already covered the atom all the way to the cell level, and I will pick it up from the tissue level. So when you're thinking about tissue in a medical context, there's a variety of tissue you can get from patients, and you can get it in several ways. So the first way to get access to medical tissue from people is actually through excretion. This is maybe not the tastiest topic, so I hope you're not having lunch right now. But you can collect urine, stool, mucus, vomit, saliva, all of these sort of things that naturally already should be kind of excreted by your body, right? So this does not involve any cutting or puncturing typically. The second type you can have is human tissue that you sample via excision. And excision is the medical term for sort of cutting. So here you can do, for example, a puncture. And in a puncture, what you're doing is you're using a needle to get access to some tissue. It could be blood, lung fluid, or other types of fluids. You can use scraping. For example, sometimes they scrape a couple of cells from someone's cheek, right? Or you could do a biopsy. And a biopsy is also sort of an excision, but the difference is that you're taking out a piece of tissue as a whole. So you're looking at something a bit more large than just a single cell, let's say, right? So it could be, for example, hard tissue, such as the bone marrow. It could be a sample of the brain, of the skin, of the liver, of the lung. Of most tissues in the human body, you can take a sample. What is interesting to note here is that although you kind of gather these samples at the tissue level, that does not mean that the analysis of the data needs to be at the tissue level, right? So for example, you could also do cellular or genetic analysis based on the same data, but the gathering of the data will still be at the tissue level when you're doing it medically. All right, taking a bit of a closer look at this last type, which is the biopsy, right? So where you gather a bunch of tissue from someone. When you want to look at this more closely, what is done typically is called histology or histopathology. And in histology, what you're doing is you're doing an examination of the microscopic anatomy, so the structure of the tissue. While in histopathology, you're looking at the microscopic identification and study of diseased tissue. So histology can be healthy tissue as well, and histopathology means diseased tissue. Now, this is a whole process. It's not like you take the sample, you take a little picture and you're done. There's a lot of work that needs to be done. So first, the tissue needs to be fixated. This prevents it sort of from drying out or discoloring or any of those things. Then you need to select and trim, basically like cut the tissue that you want to see. Then there's an embedding step where you take the tissue and you put it into some what is called an embedding media. It could be, for example, paraffin wax. Then there's sectioning, and sectioning means cutting or slicing. And finally, there can be staining. And by staining, they introduce some sort of chemical that makes stuff highlight in funny ways. So here's an example. Here on the right, you see a sample of human lung tissue, and it's stained with what is called hematoxylin and eosin. And I'm probably mispronouncing that. I hope someone will correct me on the Discord server. Anyway, what you see here is that these cell nuclei are dark blue, and then you see red blood cells in red. Good color choice there, I would say. Maybe Teresa has other opinions, but we'll find out later this week. And then the extracellular material and also the cell bodies are pinkish. And then what is white is air, so there's no sort of data there, right? So this is one way that you can look at data that comes from a tissue sample. Another way could be that your data is presented in a table. So there could be a table with blood sample values, for example, right? So these are the two main data types you can have. What are now a bit broadly speaking the visualization challenges when you're visualizing histology data? When you have such an image and you have multiple of these images and you try to stack it onto a 3D volume, there can be something difficult about that, that is deformation. So you saw already in the preparation of these samples, there's many steps, and it could be that one piece of tissue is stretched out a little bit more, or even that it gets torn. And for this, you would then need to correct for it in a sort of an alignment process, which is called registration. This can be quite challenging to do well so that your stack fits together nicely and you end up with a good 3D volume. Also, this data has very high resolution. It's looked at under a microscope. So there's a lot of detail there. And when it was still sort of manually looking at the microscope, you would have these magnification levels. They also reproduce that virtually. So you have like levels of detail, almost like a pyramid of image resolutions where you can see at magnification 10, which is the largest scale, for example, to 5 to 1, and you see the different resolutions. So to support viewing of this, you need good interaction so that people can zoom in on the data and get the details that they need. Also, what has been challenging in this type of data is proprietary image formats. That means that a vendor is selling a certain microscope and they have also an imaging format to go with that, and it's not entirely open. This is not exactly my area, but I do hear there's been some initiatives to more standardize this so that you have, for example, like you have in medical imaging, you have the DICOM standard, and to do something like that also for the microscopy imaging. The reason I think that this was a bit delayed is that it's quite recent that these things all became fully digital also, right? So it used to be quite a manual thing. You had a tissue sample on a piece of glass, you look at it under a microscope and you take it away again, right? So the scanning of these samples and digitizing them, I hope there will be an open standard available soon, which will make it easier to work with this type of data. Then you see many times that people are applying, for example, deep learning methods to analyze these slices, and then maybe to automatically extract, for example, cells or specific types of things that they're seeing. And then the question is, how should the visualization interact with these sort of automated image analysis methods? Is it enough to present the results from them? Do people need to have an option to maybe correct the results of if automatic methods are wrong? There's many open research questions here. Also, an open question is how to integrate this data at such a small scale, at the tissue scale, with data at a higher level. So if you have data from the lung, like we just saw, this histology sample, and you want to now integrate it with a CT scan of the lung, how do we go ahead and do that? That is also a challenging topic that can be worthwhile exploring. All right, moving on to the organ level. This is the level at which most of the action happens, I feel like, in medical imaging, so I spend a bit more time there. So here you see sort of an overview picture, and you see that people can use a variety of different wavelengths of energy in order to get images of the human body. So for example, you can use magnets to get the MRI signal with a radio frequency pulse. You can use infrared light, you can use computed tomography, which is based on X-ray, or you can use positron emission tomography, which is based on people actually emitting the radiation, right? So there's a variety of skills involved here also within the organ skill. So let's start with the simplest of examples, which is the X-ray. X-rays are using radiation, so electromagnetic waves, and they call this type of radiation sometimes ionizing. And ionizing radiation is the type that can do damage to people. If you have it in very high doses, you'll have instant effects, but in low doses, it may induce cancer at a later stage. So this is the type of radiation that you want to avoid getting if it's possible. If the ends justify the means, of course, you can get an X-ray, but you wouldn't do just X-ray for fun, is what I'm trying to say. What is actually leading to the image contrast when you look at these images? So here we have an X-ray of the hips or the pelvis. The contrast created is by how the tissue varies and how much of these X-rays it absorbs. So you have some sort of X-ray tube, it's shooting these rays. There's a patient in between, let's say me, and then you catch it onto a detector. And depending on how much of these rays get absorbed, you get a contrast on the image. So in this way, it's a projection image, right? So it's 2D based on a 3D structure that you kind of flatten out onto a film. When I was a radiographer, this was still an actual film, by the way, but later on they digitized this as well. Anyway, what you see here is that the bone is quite white, and this person has a hip implant. It's metal, so it's fully white. Then air is black and soft tissue is grayish. So it's quite easy to understand sort of intuitively once you've seen a couple. You can do more with X-ray than just the standard 2D ones. You can also do X-ray over time, which is called fluoroscopy. And then you can see the body kind of in motion, which is quite exciting. And what else you can do, if there's not enough contrast with the tissue originally to make it visible, you can inject a contrast agent. So this is sort of a fluid that you inject into the vessels in order to get a better contrast. And then you can do angiography, and I have an example of that here. So these are the coronary arteries, and you see some sort of thing in here, and it's adding this contrast agent, and then these coronary arteries start filling up. So you can use that to diagnose issues. For example, if there's some narrowing of the vessels, you can also use that to place treatments like placing a stent, which is this metal net that helps it stay open. Another thing you can do with X-ray is called mammography, and this is an X-ray of the breast, basically, which is very often used in screening. So here's another X-ray. If this was very interactive, I would normally do like a quiz, like what do you see here, right? So this is a chest X-ray. You have the lungs and you have the heart, which is given by sort of this whitish shape. You see some air here as well. So what could that be? Well, that's air in the stomach. Then you also, if you look closely, you see some clips here. So I made a magnification of that. So if this was an interactive lecture, I would ask you, what do you think this is? You might think it's like from surgery, right? Some clips, they had some surgery and then they entered some clips. Actually, likely it's the bra of a person. So it's a woman taking the X-ray and she didn't take her bra off. It's likely the closings in the back. Yes. So you see now what this projection of an X-ray does, right? You get everything in the same plane, so you cannot see the depth anymore. When you do want to see the depth and you want to use X-ray, you can use what is called computed tomography, or CT. And a CT scanner is basically like a tube rotating around the body, an X-ray tube. And then as you're catching this sort of data, you can reconstruct it into a 3D volume. And typically the way it's visually presented is as a stack of these two-dimensional slices. So here on the right, you see an X-ray of the chest again. It's quite different than this X-ray of the lung we saw, right? So in a CT scan, you see really a slice by slice basis. And you can see far more details than you can in a normal X-ray. In this way, in this picture, by the way, this picture is of a patient with a collapsed lung. So that's why it's so black in this area, and you see lung tissue on the other side. What is cool and easy about CT scans is that their imaging intensities, they have a specific meaning related to the tissue that's being imaged. So this is also called Hounsfield units. And it can vary a little bit between scanners, but it is pretty standardized. So you can have black in the image, that would be air at -1000. Fat would be between -120 and -90. water would be at 0, and cortical bone, that is the outer layer of the bone, would be at 500 to 1900. You see that also here in the image, right? So air is black, lung tissue is a little less black. It has a lot of air in it, but not entirely. And then you have the outside of the bone, which looks very white. Then moving on from CT scan, you also have what is called a magnetic resonance imaging scanner. And this works in a completely different way, even though the data may look a little similar at first glance. So in magnetic resonance imaging, you're working with a magnetic field. So the patient goes into this deep tube and there's a magnetic field applied, which makes all the hydrogen atoms align in a certain direction. Then using a gradient and a radio frequency pulse, these things, the hydrogen atoms that are spinning, they collapse one way, and you're measuring the recovery back to the normal spin. I don't have the time to go into these technical details, but I think this is quite exciting that you can get an image out this way at all, to be honest. So here on the left, you have an example of a regular CT scan of the head. And here on the middle, you see an MRI scan. What is also cool about MRI scan is that depending on the parameters that you set, you can end up in a variety of different tissue contrasts. So here you have what is called a T1 weighted image in the center, and you see that the brain is sort of grayish and the fluid is black and the skull is white. And on the right, you see a T2 weighted image. And here the brain is visualized completely differently, right? So now the fluids are white, the bone is a little bit gray, and then the skull is also gray, but darker gray. This, you all can already see probably, this is not so standardized as in the CT because it depends very much on how you scan. MRI is very powerful. We already saw from Anna's talk, this diffusion tensor imaging, which allows you to show like these fiber tracks in the brain, right? But you can also do a functional MRI showing brain activity, MR spectroscopy, related also to the spectroscopy that Jan was showing, but then visualizing metabolites, for example, in the brain. And you can also do angiography by injecting contrast again, similar to how you would in an MRI. And this is shown on the right here. All right, moving on, we have medical ultrasound. This works via very high frequency sound waves. And I guess the most familiar people get with it typically is through when they do an ultrasound of someone who is pregnant, right, to look at the baby. The good thing about it is no harmful radiation like CT or X-ray would have. But it is a bit more difficult to read, I would say. And part of the reason for that is that you're looking at things from maybe a strange angle, and also there's a lot of noise. Still, it's a very powerful modality, and it's quite cheap to do also, so you can have it very available to people. How it works in principle is that you have pulses of ultrasound that are sent into the tissue via what is called a transducer. So this is this device that they put on top of the body. And then the echoes of the sounds are being caught by this transducer, and this is generating the image. It can be 2D, that you scan sort of in a plane, but it can also be time varying, because you can look over time what is happening. You see that here on the right is the human heart beating. It can be 3D as well. If you scan a whole plane and you sweep it sort of around, you can get a volume. And you can also even use it to look at blood flow by using what is called the Doppler principle. So here you're using this Doppler effect, which you probably know from when an ambulance passes you by and you hear the sound changing. You use that to detect blood flow also, which is quite exciting. Then the last category I want to talk about here is nuclear imaging. So this is the most common types are PET and SPECT. So PET is positron emission tomography, and SPECT is single photon emission computed tomography. So you see the T and the CT are quite related to CT, right? So you can have a 3D volume again. But what is very different now, we don't have this X-ray tube that is rotating. Now we have something like a gamma camera, and the patient is actually emitting the radiation. So how do we make patients emit radiation? Well, you can inject a radioactive tracer. And what is interesting about this modality is that it's showing functional images. So rather than anatomy or structure, you can see actually what the body is doing internally. So you can use this to visualize metabolic processes, blood flow, chemical composition, absorption. Here also you see the difference side by side between a CT and a PET. So in a CT, you have a very high resolution and you have structural data or anatomy, and you can see a bit of pathology as well. But if you do a PET scan, you see at a lower resolution, these functional information of metabolic uptake. And here it's important to see that there's differences in where the tracer is taken up, right? So here you see two rather large blobs, which are the liver and the spleen. And then there's the kidneys. Those are healthy, that's normal uptake there. So there's no problem there. But however, you can also have activity in the bone that is highlighting to some pathological process. So in PET, in functional imaging, you have to distinguish between what is healthy physiology, so as the human body should be working, and what is pathology or disease. You can also have hybrid scanners, which are kind of the best of both worlds, I would say. So you combine, for example, a CT scanner with a PET scanner in a single device. And then in this integrated hardware, this avoids the problem of putting a patient onto one table, taking a scan, putting them onto another table, taking a scan, and then having to do the registration afterwards, which can be quite complex if you want to like overlay the images. In integrated hardware, there's less of a registration issue, but that doesn't mean it's gone entirely. Because even if you lie perfectly still in your scanner, your body internally is still having some movement, which you cannot stop. Luckily, I would say, because breathing is one of these movements, right? So that's why you still have a little bit of a registration. And here you see, again, such an example of a CT combined with a PET scan. When it comes to visualization challenges in medical imaging, one of them is artifacts. So artifacts is misrepresentation of tissue structure produced by the imaging technique. So it's showing up in the scan as something, well, that's not actually like that in the body, basically. For example, if you have metal dental implants, I have one. If you're in a CT scanner, it will scatter and it will look like you have spikes sticking out of your jaw. That's an artifact, it's not actual spikes. Fortunately, or no, fortunately, joking. Then interaction with automated analysis methods is also a very important thing, again, to think about what parts of the analysis can be automated, what parts should be interactively visualized. Integration with data at a lower scale is always a challenge, similar to how we already mentioned it at the tissue scale. And then when you're combining modalities, there's this registration issue. And later on, there will be a lecture on correlative imaging. So I point you to that lecture for more information about that. When you're doing 3D volume rendering specifically, additional challenges rise up when you're doing medical imaging rendering. And again, there will be a lecture later this week, so I go very quickly over this. One challenge is always occlusion, and occlusion means blocking the view. So there's a structure you want to see, but there's something in the way, right? So that's occlusion, that's something you need to fix. Then there can be a lack of contrast or resolution for the structure of interest. So let's say you're interested in a vessel, but there's not enough contrast with the surrounding tissue, then you cannot see the vessel anymore. And it could be that you need to do what is called a segmentation first, which is a labeling of the data. When you're working with MRI, the magnetic field inhomogeneity can be an issue for volume rendering. So with CT, the data is kind of behave nicely, right? So you have these structures and they have a certain intensity value. That means they're quite easy to select. But when you're doing MRI, the field is inhomogeneous, which means that a value here could have a higher value than a value here, even though it's the same tissue. Also, this structure intensity relation is lost immediately. In ultrasound, a common issue is noise, but there has been a lot of work on improving this as well. Now, up to the organism level, and Jan picked this very nice cat and mouse image, but actually I'll be talking about people, so talking about the whole body now. You can do MRI, CT or PET for the whole body, but I would say this is not very commonly done. There's only a few indications where this makes sense. So for example, if someone has been in a serious car accident, a full body CT could make sense to quickly determine where the most acute damage is that needs to be treated. It can also be done for metastases, so cancer spread in the rest of the body. I've seen companies offering whole body CT as a screening thing, and this is, I think, maybe, at least in the Netherlands, it's not recommended because you're doing your self-radiation dose, and there's no real indication for having such a scan done, because you might also accidentally detect stuff that would not have needed treatment in the first place. So you have a risk of over-treating. Here's an interesting modality that you, of course, cannot do on people that are living, but only on donated bodies. It's called cryosection, and it's basically like a very large scale histology. So what people are doing is on donated bodies, they freeze the body first and they embed it in some sort of material to stabilize it. And then they do section or cutting in very thin planes, and then they take high resolution images of it. And note that this is not color data, so this is original body colors. Here's another example of that, of the visible Korean human female data set. And you'll see that the resolution compared to normal medical imaging modalities is very high. So in this case, 5,616 by 2,300 and 0.2 millimeters between slices. So you have a very detailed view, but of course this requires a great sacrifice. So it's not possible to do that for people normally still alive, let's say. Moving a bit away from the imaging data, of course, there's also a lot of non-imaging data in the medical domain. And one example is electronic health records. And an electronic health record, or EHR as they also call it, is basically a collection of patient health information. And it could contain, for example, medical history, medication, test results, any allergies, radiology images, statistics about the person, or billing information. And the visualization of such data can also be quite an interesting research challenge. At VIS, there's been this repeating workshop on visual analytics in healthcare, and this is a very hot topic, I would say, to visualize these electronic health records in a meaningful way. The last skill, I'm trying to speed up so you still have some sort of break after this. The last skill to cover will be the population skill. And here you can talk about several things regarding the population. First of all, there's screening. And screening is about discovering disease among a population without symptoms. And it's more of a systematic testing of individuals to benefit people in case they have increased risk and you don't know about it, or to detect disease. Examples of this are cholesterol measurements, because this can be an indicator for the risk of cardiovascular disease, and also mammography for early detection of breast cancer. I did want to say that this should fit the risk of overtreatment, the risk of the type of scan that you're doing, like mammography, it uses Xray. The benefits should outweigh the risks of what is done. Then there's cohort studies. And cohort studies are medical research studies studying a large number of subjects over time, or longitudinal is the word they typically use for it. And a cohort is then a group of people who share some sort of defining characteristic. So for example, a cohort could be people born in Rotterdam between the 80s and 85, which would include me. Or a cohort could be gynecological cancer patients, for example, and you watch them over time and you want to see which patients have more aggressive disease versus more benign disease progression. The data is very often then self-reported interviews, so tracking people over time, you ask them the same questionnaire, but it can also be medical examinations and medical imaging data. There's a very nice survey on this topic if you're interested. Then public health. This is now a very hot topic, of course, given the global pandemic, but here you're studying the population in order to prevent disease. So the aim is to encourage behavior and policy change to limit acute disease outbreak, as we're well familiar with now, or to reduce chronic diseases and injuries. And here you have really data that is both changing over time and also changing over location. So you're having spatiotemporal data to deal with. We'll have a lecture later this week also on this very topic. What is the challenge when you're visualizing data from population studies is the data sets become really too large for visual inspection of all the individuals, right? It doesn't make sense to go for 1,500 individuals and looking at their scans and their blood values individually. You need to look at them as a whole. And for this, it is always a good idea to combine with statistical and machine learning based analysis. And then again, you need to think again, like what is the best to do automatically and what should I now do manually? Also in these larger studies, data quality can be a big issue. For example, you could have missing values if people don't fill in the interview entirely or they don't show up for a certain scan, and also standardization. So people are scanned in different hospitals, they have different scanners, and you might have to deal with some consequences of that. Coming a bit to the closing. So today we looked at data at various scales, all the way from the more biological scales to the medical scales, but there's many other ways you can look at medical data. For example, you can think about anatomy versus physiology, measured versus simulated according to its dimensions. Is it 1D? Is it 4D? Is it high dimensional? And also you can consider what is clinical, what is in use today, and what is preclinical, which means it's still in a research phase and hopefully will be used in the clinic one day. Another thing I wanted to point out is as soon as you're working with any sort of medical data, keep in mind that this is sensitive personal data that you're working with. It belongs to people really, so you should treat it very respectfully. Also make sure you're following the regulations that apply to this sort of data and check if you're unsure. Don't really assume like, oh, others will have it taken care of. Really be sure that the data you have is fine to be used for that purpose. If you have medical collaborators that you're working with and that are sharing their data and you're about to publish something, always check with them as well if they're okay with you publishing it, because it might be that they still have study findings to publish on the same data set. And if you already publish a visualization paper about this topic, then you kind of steal their thunder and they lose their impact. Finally, I wanted to give you a sort of a cheat sheet for some medical jargon in case you're not so familiar with it, because I think having a couple of these words, it can make you go a long way in understanding what they are talking about. So one of them is the directions. So when you have the body, what is called medial means to the center of the body, while lateral means outwards, for example. Anterior means the front and posterior means the back. Then you also have these planes. So the type of plane you also see in the medical imaging data, is it axial, is it coronal, or is it sagittal? That is also very useful to know about. I'll put this in the Discord channel. Sorry, couldn't find a word there. In general, when you want to do a good visualization, it requires a thorough understanding of the data that you're working with, which is a bit of what we already talked about, but also the users, like who do you intend to use your visualization, and also the task, what should you support with your visualization. And I think it's really important for us to really invest some time in finding a common ground. As soon as you enter into a collaboration, it might be that you don't really speak each other's language yet, but put in some efforts to really understand the language, but also the sort of jargon they use, because they will have the same with you. If you're coming from a computer science background, they may not know what deep learning means, for example, right? So be patient with each other and learn from each other. With this, I thank you very much.
Thank you very much, Noeska. Thank you very much, Jan, for the very nice and detailed talk. Despite the short period of time that we have available, we have lots of questions. So most probably I won't be able to go through all of them, but Jan and Noeska are very active on Discord, so they will handle the rest. So first of all, we have a question from Team Heritz. What do you think is the latest major game changer in the world of medical data acquisition? New, faster, better, more convenient technology, algorithm, etc. Anything you are particularly excited about?
I would say that one of the game changers has been this radiomics, or this thought of taking the imaging data and trying to extract extra features out of it in order to come up with kind of these you have biomarkers, right, which are related to some biological property that has something to say about the disease or its treatment. They're looking for imaging biomarkers. So using the medical imaging data, deriving features and seeing which of these features determines what is, for example, aggressive versus non-aggressive cancers, and which are good responders to certain types of treatments. So I would think that's one.
Jan, would you like to add anything, or you're covered?
I think this is mostly about the biomedical data, at least the question is. But in terms of the biology data, I would say that one of the game changers is becoming the Cryo-EM, because since we are now getting closer and closer to the atomic resolutions there, we can actually obtain the 3D shape of the molecules which were before unreachable because of the chemical properties. For example, with membrane proteins, we cannot simply look at their structure through the X-ray crystallography because we cannot create a crystal for them. But now with the Cryo-EM, we can actually look at them and see how they look like in terms of their spatial orientation.
Okay. So we have one more question here. With more and more methods emerging, I believe the explainability of the undergoing processes and results are becoming more important. Are there some advancements there worth mentioning?
I think in terms of explainability, as people are looking more and more into bringing these machine learning based methods into the clinic, the patients, they have a right under GDPR, they have a right to an explanation why decisions or recommendations were made. So I think here explainability will be crucial. Also, I think more efforts could be put on doctor-patient communication. Like if patients are to participate in their own treatment plan, they need to understand what is going on at some level, right? And I think here visualizing the data in such a way that it makes sense to non-imaging experts would be a crucial thing to do. So explaining what disease is happening, what the treatment options are, I think having your own personal data rather than an illustration might be very helpful here.
Shall I go on with some other questions? Maybe let's see. Yeah,
if you like, we can also take it on Discord so people can have a break, whatever you prefer.
I think there are a lot of questions, so maybe if you are active on Discord, it would be better for the sake of the break. Otherwise, people will start jumping out of the window.
Sure, let's not have that.
Okay, good. So thank you very much all for attending this talk.